I'm a research fellow here at the London School, and actually the current work that we are doing involves researching malnutrition, the undernutrition and overnutrition, but especially we look at what role agriculture and, well, actually the decisions that we make, the food that we eat, the dietary choices that we make in agriculture, the impact of agriculture and the impact of environmental change on agriculture and our diets, and hence the malnutrition and health outcomes. So today I'll only focus on those last two boxes, which are here. Some of you might be familiar with some of these terms, so it will be kind of a nice recap and hopefully a nice start of the discussion. For others it might be a bit newer. So basically in nutritional epidemiology, when we study nutrition and food and well-being, we look at two things. Is food available to us? Is it accessible? Is it stable? Can we use it? And then once that is in place, do we eat the right quantity of food? Do we eat the right quality of food? You can think about, for example, toxins on the outside of food products, or pathogens, for example. And how then together does that lead to nutrition-related burden of disease and well-being. And this is actually part of a much larger framework, which today we have submitted to a journal, so hopefully I can tell you a bit more about, or you can read more about it in a little while. So if we talk about malnutrition from an epidemiological point of view, there's actually a few indicators that we find interesting. One is the stunting, so that is the low height for age. This usually has to do with the quality of the food, the nutrient deficiencies, for example, that might lead to a lower development in the children. So they're not extremely thin, but they are much shorter than their non-stunted counterparts. Wasting, which is the low weight for height. And then at the other side of the spectrum, of course, also obesity, so the high weight for height. And then there is sometimes, especially in WHO reports, they also use childhood underweight, which is a slightly older term, and that's low weight for age. And you can imagine if you're stunted, that then your weight, if you are have a normal body size, is also lower. Epidemiologists love graphs, and this is one of them where we looked at how are we doing in, for example, the Millennium Development target of halving wasting in children under 5 in 2015 with the baseline year 1990. And well, we haven't exactly halved it, but we're quite well on our way. And again, of course, this is adopted in the Sustainable Development Goals that are now in place. And these are some trends of the different the different continents, where you see that Oceania is actually the only one where it's going up, but they contribute quite a small amount to the total world population, because the populations that are quite small. So the trends in stunting are, so this graph is wasting, sorry, this is the stunting one. So we see that in Asia that is going down quite a bit, and in Africa it's still rising, and in Oceania as well. But if you look at total numbers, although in Asia it's come down quite a bit, just because of the massive populations we are talking about, still 6 out of 10 children that are stunted live in Asia, and 4 out of 10 in Africa, more or less, and then there's a very small proportion living elsewhere in the world. So although they've gone a long way since 1990, yeah, it's still like a very persistent problem in Asia. And at the same time, interestingly, you see that obesity rates in childhood disease are significantly going up. And this is something that is also referred to as the double burden of disease, something that kind of is a byproduct, so to say, of development, where you see that in some areas where people become more affluent, they start eating other diets. There is more problems of obesity, diabetes, and all kinds of diseases related to that. But at the other hand, you still have your undernourished children, the stunted children, etc., etc. And what is very important in that is that health systems need to be able to care for both, because very often there are feeding programs and so in place. But now you're dealing with both the feeding programs, the nutrient deficient children, etc. And then at the other hand, you need to have your services up to date also for the slightly longer term management of obese children. So I just wanted to show you a few slides on how we measure malnutrition in epidemiology, and this is called the LIDC-DTC Nutritional Assessment. I think a few of you might have come across this before. So the A is actually step 1. It's the anthropometry, which is, for example, the height, the weight, the BMI, the mid-upper arm circumference, and that is usually kind of the very first step in when you suspect that there is a high prevalence of malnutrition. It's quite rapid. You don't have to take all kinds of urine samples or blood samples or other tissue samples. You can measure it. So these things are used for prevalence surveys, for example. It enables rapid action because you can very quickly establish that someone is malnourished, and they can be put on complementary feeding programs. What it doesn't tell you if there is a specific micronutrient deficiency in those children, for example, and if apart from complementary feeding, they also need a supplement of a certain mineral or vitamin. But that is taken into account in that second step, the B, the biochemical analysis. So this is where we do analysis in blood, urine, stool, and other samples. And there, for example, you can measure the hemoglobin levels, which will be an indication for anemia. So you would be able to treat the patient accordingly very quickly. But you can imagine that it's not something that you can just roll out on a population basis, do a screening, because it's much more expensive than anthropometry. The C then stands for clinical diagnosis, and this is actually a slightly further stage in the disease, and this is actually when malnutrition has already progressed into a disease and someone is really experiencing the consequences of that. So I had a little quiz. Anyone familiar with any of those diseases and what mineral deficiencies they're coming from? The right one you might be familiar with. No.
The middle one is iodine deficiency.
Iodine? Yeah, exactly. Yeah, it's a goiter. It's an overactive thyroid gland. Yeah, exactly. And then the left one is hypocalcemia, which is a calcium deficiency, and the right one was iron anemia. And so same for mineral. Anyone recognizing anything of these pictures?
First one is C.
Sorry?
The first one on the other side is Caveri.
Yeah.
Vitamin C. The last one is D, rickets.
Yeah, rickets, yeah, and the C is actually, the scurvy is the second one. The first one is pellagra, where you get very sensitive to sunlight, for example. And the third one refers to the night blindness that you might get when you have a deficiency of vitamin A. And then we come to dietary assessment, and I wanted to spend the last 5 minutes on this. And this is something where you can look much more into what do diets of this population comprise of. Is there an indication, if I look at their diets, that this population is very susceptible for a high prevalence of anemia, a high prevalence of zinc deficiency, and a high prevalence of any vitamin deficiency? And there's several tools for doing that, and you might have come across a few of them before. So one is for example, a food frequency questionnaire, where we are listing a certain number of food items that might be commonly eaten in the specific population that you are studying, and then they indicate how often they eat this in the year. There are quite a few limitations to this method, but the advantage is that if you are specifically looking, for example, for food items with a lot of zinc, or food items with a lot of salt, or sugar, you can target, so you don't have to ask people about their entire diet, but you can list the ones that are the most eaten items with a high salt or sugar content in that particular area. But you can imagine that seasonality or so is something that is very difficult to account for in this method. Another option is the 24-hour recall, which seems to be a little bit more valid than a food frequency questionnaire often, where people write down what exactly they have eaten in the past 24 hours. You can imagine that also this has its limitations, because was this a weekend day, was it a Monday, was it a day where you were late at work, was it your birthday? Of course, it has to be kind of a representative day, and there are methods how to overcome this. For example, to ask about the 2 days, or that people keep diaries, so they do it for a week, for example, or you do it multiple times. You repeat it the next month, and then over the course of the study. But more recently, like probably in the last 10 to 15 years, biomarkers have taken a much larger role in nutrition, measuring diets and nutrition in populations as well, which obviously come with a cost, but they are much more precise. You can measure exactly in someone's blood, or in other in serum samples, for example, what elements, what minerals, what vitamins have been consumed. For some nutrients, dietary data are very inadequate. For example, the salt questionnaire. This is one of the questionnaires I set up for a study in Bangladesh, where we looked at salt in drinking water. So we had to adjust the salt in diet, of course. It's very hard. Like, how much do you add? Well, a pinch. What is a pinch? Like, someone finds this a pinch, and another one takes a quarter of that. So much easier is then to collect urine samples and measure the salt in urine. Although there is a little bit of an error in that. For example, when people sweat a lot, when they are rickshaw driver, for example, and also with your stool, part of the salt might leave the body. But yeah, it's much more objective. Of course, there is lots of social desirability also attached to asking people about their diets. So the measurements, biomarker measurements, are much more objective than those dietary surveys. And if there are any errors, they're very likely to not be related to what you are actually studying. So there might be some errors, but they are in both of your comparison groups, so they don't jeopardize the validity of your study so much. That's the point. Problem is that we don't have biomarkers for everything. So still we have to rely on, these are some of the biomarkers and the food and nutrient that they reflect. But yeah, we don't have this for everything. So still we have to rely on a combination of these methods, most probably. And then the last thing I want to end with was that measuring malnutrition in any form, so through the anthropometry or through the biomarkers, through the frequency questionnaires, and especially when we then look at prevalences of malnutrition, prevalences of nutrient deficiencies, are actually only one part of the story. This is one part of the burden that malnutrition is actually causing in a lifetime of a person. And just to give you a few examples, there's lots of studies currently on their way to measure what, for example, if you're stunted in early childhood, what kind of problems or burden of disease or increased risk of, for example, chronic diseases you might have in later life. And I always have these discussions with my family when my mom and dad said, but do they still not know what the lifelong effect of smoking is, for example? But of course, if you do life course studies, take a life course to study, because you need to enroll children at a very early age. And so yeah, that's like 60, 70 years we're talking about. But one of the studies, there's obviously quite a few case control studies which give you also quite a good indication of what stunting and wasting might do to children later in their life when they're adults. And one of these studies is from Hoffman and colleagues, where he looked at rest energy expenditure as in children. Well, they're now adults, but they were stunted when they were children versus adults that weren't stunted when they were children. And you see that the rest energy expenditure of those that were stunted in early childhood is much lower, is significantly lower than their healthy controls that they are compared to. And this obviously means that in the end they are more likely or at higher risk of developing obesity, diabetes, and high blood pressure, and all those diseases that are related or on the causal pathway of that. And another example is the fat mass versus the lean body mass that the children develop in later life. And you see that the top one is the fat mass in kg, and the bottom one is the fat mass in percentages. So it's pretty much showing the same. But the grey ones are the children that were stunted in early life, and the white ones are the ones that weren't stunted when they were a child. And you see that, especially in boys, the fat mass is much higher in boys that were stunted in early life, and the lean mass is much lower in boys that were stunted. In girls, you see a similar effect, especially the lean mass. There is a significant difference, but in the fat mass, there's not so much of a difference. And I think that's also because girls in general have of course, a higher percentage of fat in their body. So, in the interest of time, I would like to leave it with that, and I hope, even although you might have heard about this before, we could have a bit of a discussion about this later on. And I'll give the floor to Sarah.
Thank you. Yeah.